Welcome, and thank you for joining us today for Trauma Screening, Brief Intervention, and Referral to Treatment, otherwise known as T-SBIRT, Introduction to a Promising Brief Protocol for Social Service and Healthcare Settings. I am Luke Waldo, Director of Program Implementation and Community Partnerships at the Institute for Child and Family Wellbeing, and I will be hosting the welcome and Q&A portions of today's webinar. To begin, please note that all audience members are muted today to ensure that everyone can hear the presenters. We would like your questions as they come up throughout the presentation, so please use the chat and Q&A functions found at the bottom of your screen to submit those questions. Please submit them to all panelists, which you will find in the chat dropdown. The presenters will answer your questions during the Q&A at the end of the presentation. Finally, you will receive a survey upon exiting the webinar today. We value your feedback, so please take a couple minutes to complete it. We will also send you supportive materials from today's presentation in an email next week. Thank you again for your participation today. It's my pleasure to introduce our presenters. Megan Christian serves as a child and family therapist at the Institute and Children's Wisconsin. Megan previously served as a well-being assessor for the Institute and Children's as well. Dimitri Tepitsas is a professor at the University of Wisconsin-Milwaukee's Helen Bader School of Social Welfare. He also serves as the clinical director at the Institute and is the developer of the T-SBIRT protocol. Lisa Ortiz is a supervisor at UMOS who has led the implementation of T-SBIRT at UMOS over the past 3 years. Welcome to you all, and without further ado, I will hand it over to Megan Christian.
Hello, everybody. Thank you for joining us for our T-SBIRT webinar. We're going to start off with Dimitri, questions to Dimitri Tepitsas. Dimitri, can you jump right in and tell us what T-SBIRT is and give us the nuts and bolts of what it is?
Yes, of course. Hi, everybody. Dimitri Tepitsas here. Welcome. Delighted to be able to present the T-SBIRT protocol to you all. We're going to boot up our slides. There we go. And talk at some length about trauma screening, brief intervention, and referral to treatment. So that is what the acronym T-SBIRT stands for. It's a simple 10 to 30-minute interview protocol. It's implemented within a number of different health or social service settings, and its purpose is severalfold. First, it's meant to help clients or patients identify trauma exposure that they have encountered throughout the course of their life. Also, to define or identify and home in on the symptoms that they've experienced or the consequences that they've undergone or endured as a result of trauma exposure. It helps, when we do this, it tends to increase clients' or patients' awareness of their experiences, of their history, for instance, as well as their awareness of and acceptance of and normalization of their experiences of trauma symptoms, trauma consequences. That shouldn't be minimized, because when I'm able to understand, oh, my behaviors or my experiences are as a result of being exposed to a good deal of adversity over the course of my life, I sort of give myself a little bit of permission to recognize that this wasn't my fault. This was something that was a natural result of exposure to a lot of adversity. Thirdly, we implement this protocol in order to motivate or enhance clients' and patients' motivation to accept and to complete a referral to treatment, mental or behavioral health treatment, for instance, or a referral to other related services, such as intimate partner violence services or DV services. Many people who've experienced a great deal of trauma exposure and have endured the consequences or symptoms of trauma exposure have not necessarily identified them and then sought help as a result of these symptoms and this exposure. And finally, we implement the protocol in order to enhance or reinforce positive coping behaviors that people have marshaled in the aftermath of trauma exposure. Next slide, please. Great. Thank you. We've developed the protocol in the context of a screening, brief intervention, and referral to treatment training program at University of Wisconsin-Milwaukee. So screening, brief intervention, referral to treatment, or SBIRT for short, like T-SBIRT, is a brief protocol or interview protocol that targets substance misuse. And what we found when we were implementing and casing the literature around T-SBIRT is that, around SBIRT, the SBIRT for substance misuse, is that it didn't do a great job of addressing deeper end substance misuse problems. Does a really nice job of addressing effectively substance misuse problems that are harmful or hazardous in nature, but not necessarily disordered in nature. So these deeper end substance misuse problems don't necessarily respond well to SBIRT for substance misuse. We hypothesized that, well, firstly, people in the social work world, which are the people that I serve, they are interfacing with a lot of deeper end substance misuse problems. And if they're doing so through SBIRT, they're not going to be as effective as they potentially could be. So we hypothesized that one of the reasons that these deeper end cases were not responding well to SBIRT was because there was co-occurring trauma-related problems. And so we thought if we combined SBIRT with T-SBIRT, we would do a better job of serving these cases. Next slide, please. So essentially what we were hoping to do, as this figure shows, is to fill this gap between severe substance use problems and past trauma exposure and current traumatic stress. The trauma exposure and traumatic stress weren't being addressed solely with SBIRT for substance misuse, so we wanted to be able to address that. Now, however, we use SBIRT, T-SBIRT, excuse me, we use trauma SBIRT both in concert with SBIRT for substance misuse, but we also use it as a standalone brief 10 to 30 minute intervention. The structure of T-SBIRT is as follows. We screen for 3 categories of experience. First and foremost, we introduce trauma with the term stress or stressor. We don't right off the bat say, what are the past traumas that you've experienced? Instead, we segue into that more sensitive conversation with an initial conversation about current stressors. So we ask clients with an open-ended question, what are the current stressors that you're experiencing? Secondly, then we segue or transition into questions or screeners about past stressors, synonym for trauma exposure. So we'll say, what are the past stressors, or AKA traumas, that you've experienced? And in order to screen, we deploy or we use the THS, the Trauma History Screen, which was developed by Prins and colleagues in the 1990s. We also use, depending on the context, screeners that we've developed at the Institute for Child and Family Wellbeing, including the CES, or Childhood Experience Screener. After screening for trauma exposure, then we screen for trauma symptoms, the consequences of being exposed to significant potential traumatic events or circumstances. And the symptom screener we use is what we call the PCPTSD, the Primary Care Post-Traumatic Stress Disorder Screener, well-validated, 5-item brief, simple to read screener that gives us a sense of whether or not someone is struggling with some form of post-traumatic stress. Following our screening protocols, then we transition into our brief intervention protocols, or components of the protocol, I should say. And in this particular phase of T-SBIRT, we ask people open-ended questions about coping. First, we ask, what sorts of positive coping mechanisms do you use when dealing with this stress, current stress, past stress? And the vast majority of the people that we have served thus far, well over 600, have acknowledged positive coping mechanisms, the use of positive coping mechanisms. So in other words, resilience. And then we segue and transition into a question about unhelpful coping skills. We'll say, well, great. Now, many people we know in the face of a lot of stress will invoke or use some unhelpful coping skills. Are there any coping skills that you use that you would like to change? This is the language we use. We don't use sort of stigmatizing language like negative coping skills or harmful coping skills, but skills that you would like to change are unhelpful coping skills. And the vast majority of people that we have served share examples of coping skills that they would like to change. For instance, substance misuse, excessive use of anger, social isolation, etc. And then we say it can be difficult to change these coping skills without outside support, without the support of some formal or informal social force. And we mentioned that oftentimes these coping skills just help us kind of manage negative emotions associated with stress, previous or past stress. And it can be difficult to get out of this sort of self-managing or self-medication coping pattern. That's useful to use other people or to use the support of other people. And we share that information in order to enhance motivation to accept a treatment referral. And that's the next phase of the T-SBIRT protocol is we conduct warm referrals in the moment to mental or behavioral health services or other related services, as I mentioned previously, like domestic violence or intimate partner violence services. And we actually make the phone call oftentimes in the session during our T-SBIRT session with well-known referral network partners in order to set up an appointment for the patient or the client with whom we're working right at that point. After we make the referral, we engage in what we refer to as participation enhancement intervention. That increases the probability that clients will attend and complete the referral. You'll see in our demonstration, we ask questions about the likelihood that someone would be able to attend the referral, and then the likelihood that someone will be able to continue to visit the person that they're seeing after their first visit, and we problem solve any anticipated problems that clients share with us or that patients share with us. And then we conclude the protocol with a question about people's state of mind. We do know that the vast majority of people can tolerate quite well sensitive questions about trauma exposure, but there is a small minority who might find it distressful. These questions may be a little bit distressing, and so we want to be sure we catch those folks, we identify them, and we provide a evidence-based grounding exercise that brings them back into the present instead of wallowing, if you will, or struggling with past memories. The vast majority, I'll share results with you later, but the vast majority of our clients say they're doing fine in the aftermath of the trauma screening, brief intervention, and referral to treatment protocol. Next slide, please. Briefly, the elements that we integrate into the T-SBIRT protocol include the following. It's very consistent with motivational interviewing and client-centered interviewing elements and practices. So first and foremost, we ask clients and patients permission to discuss stress and trauma. We'll talk about this later, but we let them know why we're doing it, but then we also ask permission to do it. And then while engaged in the protocol itself, the meat of the protocol, the body of the protocol, we invoke the following motivational interviewing skills: asking open-ended questions, affirming clients and their responses, for instance, their positive coping skills, affirming their resilience, reflecting responses. So clients will share their experiences of adversity. We reflect those experiences, not because we want to dig deep into that experience of trauma exposure, but because we want to let them know that we're right there with them. We summarize responses, again, so clients can recognize that we're paying attention, we're very present, but we also summarize responses to contain the interview, to contain the T-SBIRT session. We don't want these sessions to dig deep into the trauma exposure. It's not indicated in an assessment context. And so we use summarization to contain and move the session along. And then we provide information about typical experiences of trauma, typical symptoms of trauma exposure or consequences of trauma exposure, again, to destigmatize and normalize people's experiences. And as I mentioned previously, this is all motivationally based and client-centric. Next slide, please.
Dimitri, how have you made sure T-SBIRT is culturally sensitive?
So that's a great question. We are asked that question often. We have interfaced with the literature and interfaced with our great community partners, such as Lisa Ortiz, to improve the cultural sensitivity and responsivity of the protocol. And I would argue there are a number of ways in which it's culturally responsive. First and foremost, as I mentioned earlier, we ask permission to actually conduct this protocol. There are some, a small minority, 1% we have found thus far, some people who won't, who refuse to take the protocol. They're not interested in having this conversation within a healthcare context or a social service context. And that's totally fine, because we let them know concomitantly that this is it's totally voluntary. It's not obligatory. It's not required. And as we know through motivational interviewing research, that once we ask that question and once respondents say, yes, I'm willing to have this conversation, they tend to be more engaged and they tend to be more regulated because they've agreed to it, they're prepared for it, etc. Secondly, we ask, to the extent that we can, we ask open-ended questions. Now, our validated screeners around trauma exposure and trauma symptoms are not, those don't include open-ended questions, but our questions about current stress and about coping skills, those are open-ended questions. And there are times that we will ask open-ended questions about trauma exposure in follow-up to our screening questions. So if someone shares with us that, yes, I've had this experience, they endorse the experience, say, of a physical assault, we can follow that up with an open-ended question. Well, could you tell me a little bit more about that? Or what happened during that time? We don't want to dig deeply into the details. However, if it looks as if the client is interested in sharing some details, they're sort of brimming with more information, then we'll ask, and then we will affirm that and contain the conversation and move it along. It's a strengths-based intervention, so that fits my understanding of cultural sensitivity, in that we ask about positive coping skills. Oftentimes people will argue that trauma-informed care is pathologizing in nature. We push back on that assertion. And we reply, or we argue that, in fact, when having conversations about trauma exposure, adversity exposure, we can also pivot and easily have conversations about resilience, post-traumatic growth, positive coping, excuse me, and really reaffirm the client's experience of strengths, resilience, et cetera. So a client isn't just their problems, they're much more than just that. Our referrals also, another way in which I think we're culturally sensitive, our referrals aren't solely to formal mental and behavioral health treatment settings. The vast majority of our referrals are, but we also refer, as I mentioned earlier, to other service systems like Sojourner Family Peace Center and other domestic violence or IPV services. But we also are interested in brokering connections with more informal settings and services, such as churches, family supports, and we can really reinforce or support clients in their efforts to reach out to more informal service systems. In fact, we are just finishing now a qualitative study where we asked some of the participants in our T-SBIRT pilots how they cope with and heal from trauma. And many of them discuss formal support such as mental health services, but many of them also are sharing with us information around informal supports, and we're trying to bake that into our T-SBIRT conversations and referrals. We have identified challenges to completing referrals, particularly for clients who are facing a lot of other stressors in their life. So for instance, financial challenges, et cetera. And so we ask questions, I mentioned this earlier, we ask questions about what will be the challenges in completing that referral and making that first meeting. Clients will mention, well, transportation issues, and we problem solve with them and see if there's anything we can do to support them. If we give bus tickets, whatever it is we can potentially do within our power, we do to enhance the probability that they will complete that referral, honoring that there are many clients that we work with, that we serve, that are facing a lot of logistical challenges in their life, and we want to help facilitate their ability to overcome those challenges. And then lastly, we'll ask again, we'll ask the question, how likely is it that you'll complete the services? And some clients will say, well, it really depends on whether or not I like the interventionist, the treatment provider. And then we'll ask, well, what is it you think you would like in a treatment provider? Many people will say, well, I prefer a female to a male, for instance, if it's a woman and she's experienced sexual abuse. And so we ensure that we refer to a female. So, if we're working with clients of color and they share with us that they would prefer to work with a provider of color, then we have a network of providers who are providers of color, professionals of color, and so we make referrals to them. So we do the best we can to follow and honor cultural matching. These are ways in which we integrate cultural sensitivity into our protocol. Thanks for the question.
Thank you, Dimitri.
Yeah.
With whom have you used T-SBIRT, and what were the outcomes?
Great. So, so we've implemented T-SBIRT currently across a number of different, relatively diverse service settings. We've integrated within community-based primary care clinics that serve Central City communities here in Milwaukee, north and south sides. We've integrated within a nurse home visiting program in Racine, within ongoing home visiting programs across the state of Wisconsin. We've integrated it also within employment service programs in Milwaukee, including temporary assistance to needy family programs, such as the program that Lisa supervises at UMOS Inc. So those are the different areas that we've integrated the protocol within. And we have conducted several different feasibility studies over the course of the last 3 years, and our findings are promising from just a sort of a objective point of view. So first, we found that the protocol is suitable. In other words, we are addressing a common problem amongst the patients and clients we're encountering. So for instance, in the primary care pilot study, 92% of the patients that we served endorsed exposure to at least one significant lifetime traumatic experience. Over 55% screened positive for PTSD. That's an extraordinarily high number. Studies suggest that at any one time, there's about a 4% prevalence of PTSD in the population looking back 6 months. This looks back just a month. So that's a very high number, 55%. And we found that patients accepted referrals at the rate of nearly 63%. In other words, 2/3 of the clients or patients accepted referral to treatment as a result of the protocol. Next slide, please, Megan. And in our employment service context, the results have been somewhat similar. So 97% of the clients that we served endorsed exposure to one or more lifetime experiences of trauma. 90% endorsed exposure to 2 or more experiences of trauma, and 66% or two-thirds of the clients that we served endorsed exposure to 5 or more lifetime traumas. That's a very, very high number, very, very high rate. Global rates of exposure to 5 or more traumas is something like 25%. So we're serving high risk clients at risk for significant trauma exposure. Positive PTS screening results over 50% again in this client population, very high. Last slide, please. Finally, we found that the vast majority of our clients, as I mentioned earlier, in this particular trial, in the employment service trial, endorsed the deployment of positive coping skills. 98% suggests that there's a lot of resilience and strength out there. But 85% endorsed exposure to unhelpful coping skills. Now, why I find that intriguing is because it tells us that they trust us enough to talk about these issues by the time we get to that point in the protocol. So that's, to me, encouraging that people are willing to have that conversation with us, because it's a client-centered and motivationally based protocol is my hunch anyway. I think that's it. Next slide. Oh, finally, Past traumatic experiences. We've gone over this, but one last thing I do want to share. A couple last things. So 73% of the clients that we spoke with accepted a referral to any service system, not just mental or behavioral health service systems, around 50% for that, but 73% for other related service systems as a result of completing the protocol. That was exciting to us. And then lastly, 94% of the clients with whom we worked said they felt the same or better after the protocol. 6% said they felt worse. Of those 6%, a very small minority accepted the grounding exercise. They felt worse, but they were fine. They were able to go about their day. So that tells us that this is a relatively tolerable protocol. So that's it for my content for now, and we'll talk again. We'll talk again soon. Thank you.
Thank you, Dimitri. I'm just seeing if Lisa, can you share your screen? And I would like to ask you about what your experience of T-SBIRT has been. Dimitri, it looks like we may have lost Lisa. Could you, while we get her back in, could you just discuss briefly what you have heard her share before?
Sure, and Lisa, once you come back in and unmute yourself, just jump right in. So absolutely. So Lisa and her team have done an incredible job. There she is. Hey, Lisa. Can you hear me?
Can you hear me?
Yeah, there you go. So go ahead and share with our audience the benefits that you've seen participants experience, or the benefits that have accrued. Oop, seems like we lost you again. Well, I'll start, and hopefully Lisa will have an opportunity to share her experience. Lisa is a supervisor at UMOS Inc.
Hi, my name is Lisa Ortiz, and I would like to talk to you about the benefits to participants. So again, once again, I work with the Employment and Services TANF program, and we have used the T-SBIRT. Over the years, we have used a variety of tools that aim to find out the potential barriers, or just identify areas in a participant's life that they may be struggling with, such as participating, seeking employment, maintaining employment, or just having an overall effect on their well-being. As Dr. Dimitri has highlighted in the previous slides, the T-SBIRT has been very successful in doing that. So I would like to move on to the benefits to participants. Next slide, please. Okay, with the populations that I work with in the Workforce Development TANF program, we initially focus the use of the T-SBIRT protocol on individuals from specific caseloads that we refer to as the W2T population, which stands for Wisconsin Works Transition. This group of individuals we identify as individuals with severe barriers, or the harder to serve individuals. Later, the agency decided that once seeing the effects of the T-SBIRT, we decided to offer it to the entire population that we work with, because we understand that many deal with adversities and they may benefit from additional support services. So we offer the T-SBIRT to all participants, and this allows us to be able to work with their needs up front. In the beginning, participants may be a bit reluctant. However, we provide a brief description about the T-SBIRT protocol and assure them that they'll only answer what they feel comfortable answering. We also make it a point to address the correlation between stress, past experience, post-traumatic stress, symptoms and how this combined may affect their daily life and ability to perform their work activities that we require in the work program, TANF program. In doing the T-SBIRT, we also found that it helps build better relationships with participants and the agency. Participants leave with a feeling that the agency does care about their health and well-being and their ability to move forward. So we're not just focused on their ability to complete the requirements or activities. We also want to make sure that they're being held in the areas that they may need. So based on my experience and feedback from participants, they appreciate being heard, being acknowledged, and cared enough about to be asked about their past experiences. As a result, participants tend to trust more. They experience a vulnerable moment in a safe and understanding environment. So moving on to the benefits to professionals, provides insight on participants' needs as well as their strengths, helps us to determine what services and referrals may be needed. Often they may require services other than mental health or substance misuse treatment. So I have an example that I would like to share. I conducted the T-SBIRT on a participant who experienced multiple adversities as a child and as an adult. And to her, this was a normal life experience. During the protocol, participant showed no emotion when discussing some facts about her childhood, such as her mom having her do sexual favors for men in return for money. She experienced severe physical abuse, emotional abuse, abandonment since the age of 12, and she was homeless at the age of 12. She was picked up by a family. She did not attend school. She was not allowed to go anywhere. She was required to bring income home in the same fashion that she did as a child. Participant was not able to make decisions. She was without consulting with the family. As a result of the T-SBIRT and having some time to think about accepting potential referrals, the participant agreed to accept a referral. In this case, we knew we had to address the participant's immediate needs first. The participant was referred to an agency that works with victims of human trafficking, so that's another resource where we referred. We referred for legal services, for restraining orders, and referred and accepted for housing. We assisted with finding medical providers as well. If the T-SBIRT would have not been offered and accepted, the participant's experiences and circumstances may have continued to go unknown and unaddressed because this was not information participants shared with any other professionals. So I asked the participant what made her feel that she could open up to me, and she said she felt comfortable, she felt she could trust. As a child, there were many workers involved with her case and they never helped her. So she said this made her feel like we were really there to help her because we listened. So benefits as a professional. We as professionals can share what we know on how toxic stress, adversities, and symptoms may affect life outcomes and provide information on how the treatment can be helpful for those experiencing this. So in addition to briefly discussing, we also ask if we can share the trauma fact sheet with them to read at their leisure. And this helps the individual understand that there's nothing wrong with them. Rather, the way some respond are simply natural reactions to some of their life experiences, and stressing the fact that we do not all respond in the same way. Again, based on my experience and having this empowers the individual. For all participants, we acknowledge their experience and provide feedback on their positive coping skills, and also take a look at coping skills that may have led or lead to other problems. T-SBIRT allows us to take a look at the individual and their experiences, with the question being, tell me what's wrong, tell me what happened to you, rather than looking at them as what's wrong with you. To me, this makes a difference and does not lead anyone to feel judged. It has been my experience and supported by the findings that more than half of the participants that complete the T-SBIRT accept a referral for treatment. So moving on to the difficulties. Depending on the agency and their commitment, there may not be enough staff or time to dedicate to the follow-up needed with participants. Although many participants accept a referral, many require frequent reminders, motivation, assistance rescheduling, or just finding the right provider that the participant feels comfortable with. Also, because participants feel heard, acknowledged, and feels the genuine care and concern, participants often want to return to meet with the interviewer, and this shows the positive impact that this has on the participants and the connections made, although it is difficult at times to be able to continue to meet with someone. It is also difficult when other professionals in the agency do not understand the profound impact of the T-SBIRT and how this 15 to 30-minute encounter can lead to discovering much more and serve to improve relationships between the participant and the agency. So moving on to the considerations for success, please. This has immediately assisted individuals in engaging or re-engaging in support services, as I stated previously. The entire agency needs to understand the value and how this can help populations being served. This is very important. Everybody really needs to be on board with this. And we must be administered by individuals that are empathetic, sensitive, non-judgmental, and genuinely care about the well-being of others. Participants can sense when it is just a questionnaire to complete. So that's very important to remember as well. So to all listening, again, based on my experience and feedback from participants, my final thought would be, as we all continue to be committed to making a positive impact in the lives of those who seek our services, the T-SBIRT is and will continue to be a very powerful tool. T-SBIRT allows us the insight we may need to make significant, meaningful differences and appropriate referrals. I would strongly suggest that time, dedication, funding, and resources be allocated to administering and follow through with the T-SBIRT. And in closing, I just want to thank everyone for allowing me to share my opportunities or my experiences, with the T-SBIRT here in the TANF and Employment Services Program. Thank you.
Thank you so much, Lisa, for providing your expertise as a user of this and how it's changed your current services. I'm wondering, Dimitri and Lisa, could you give us an abbreviated walkthrough of the T-SBIRT protocol?
We sure will. Firstly, I just want to thank Lisa for sharing her experience of implementing the protocol, supervising those who do implement it. It's just been a treat to work with her team and to work with her. She is an incredibly skilled practitioner, as you can tell, and a wonderful trauma-informed care interventionist, quite frankly. We will address questions with the final 15 minutes. We have resources that are available. T-SBIRT is open source.
I can't hear anything.
Oh, you can't hear me, Lisa? Can you hear me now, Lisa? Huh. Well, let me just say this. We will address the questions after we complete a brief demonstration, if we're able to do the demonstration. We do have resources available for everybody. T-SBIRT is open source. On the ICFW, or Institute for Child and Family Wellbeing website, there are a number of resources that will direct you to, including the integrity checklist for the T-SBIRT protocol, also including an issue brief that we've published on the T-SBIRT protocol, the fact sheet, Understanding Trauma fact sheet that Lisa just referenced. And there are a few other resources that we will make available in the near future, including the T-SBIRT manual and a demonstration video that has been, one of those is complete, the video is complete, the manual is near completion. These are open source. If people are interested in consultation, ultimately in receiving consultation on T-SBIRT protocol, we'd have to work that out through the Institute. That would not necessarily be open source, but all the materials are open source. Okay, without further ado, Lisa, can you hear me now?
Lisa cannot hear you, so I am going to be your respondent, Dimitri.
Okay, fabulous, fabulous. Well, all right, so I'm just going to share a little bit of, provide a little bit of an insight or a little window into how we conduct the T-SBIRT protocol. And Megan will sort of play the role of a client. Everything that she shares is going to be completely fictional. This is just for demonstration purposes. Okay, so we'll start right away. So Megan, welcome. Good to see you today.
Thank you for having me.
I'd like to talk today about stressors that you've experienced in your life, both in the present moment and in the past. And the reason I like to do that is so that I get a better sense of the challenges that you faced and are currently facing, and so that ultimately I can serve you more effectively. Are you willing to talk about that, current and past stressors?
Yeah.
Okay, great. So just briefly, would you be willing to share with me what are the current stressors that you're facing in your life right now?
Well, my husband is out of work, and I have to go to work, and we have kids, and we don't have daycare right now, but he's not really that comfortable with taking care of the kids all day.
Okay. Okay, so family.
My mom is sick too.
Okay.
Sorry.
Okay. Okay, so family and work challenges are pretty significant right now, pretty pressing.
Mm-hmm.
Okay.
Yeah.
Any other stressors that you're currently facing?
Well, I'm not really certain that I, can keep working. Business has been slow, and so I am working right now, but I'm not sure that I'll have a job for,
Okay.
in the future.
Okay.
That's really, that's the big one for me right now.
For sure. Okay, so these are significant stressors in the present moment. I appreciate you sharing them with me. Unless you have any others, is there anything else that you'd like to share about the current stressors right now?
No.
Okay. I'd like to transition then to talk about past stressors that you may have experienced. Sometimes refer to these as traumas. Have you ever been in a natural disaster, like here in Wisconsin, a tornado or a severe thunderstorm where there could have been some problems at your house, anything like that?
Well, back several years ago, there's a flood in my county, and we were shut down for a week or so.
Okay.
My basement flooded.
Okay. Okay. Sounds memorable. That sounds like a difficult memory that you have?
Yeah.
Okay. All right. Have you ever been in a house fire?
No.
No. Okay. Any car accidents in your past?
Yes. I actually, I still have back pain from that.
Okay.
And sometimes I can't work.
Okay. Okay. I'm sorry to hear that. We know that when we have experiences like this that lead to physical injury, they tend to not only be more physically damaging, but also kind of more difficult to manage psychologically. So I'm sorry to hear that. I'm going to transition and ask you about questions about interpersonal trauma. These tend to be a little bit more difficult than the type of experiences that we've just covered. All these experiences are difficult, but I'm going to ask you about interpersonal trauma. And you do not have to answer, but if you're comfortable answering, it would be helpful to hear if you've had any of these experiences. When you were a child, did you experience any physical abuse? In other words, any kind of intervention from an adult that led to physical injury, or was just very difficult to endure as a child?
Yeah, I remember being scared of my dad.
Okay.
He would get really angry sometimes.
Okay. Okay. And when he became angry, did he become physical also?
Yeah, there was sometimes he would like punch walls. A couple of times he hit me.
Okay. Okay. Thank you for telling me that.
My sibling got the most of the physical
Okay.
abuse, I guess.
Okay. Okay. Not uncommon, but still really unfortunate. I'm sorry to hear that. How about as a child, any adult interact with you in sexual ways, make you interact with them in ways that you were uncomfortable with sexually?
Not an adult, no.
No. Okay.
Um,
Any
I had a
any
cousin.
sexual experiences that you remember as a child that that were unwanted?
My cousin touched me. He molested me.
Okay. And from any experiences sexually as a child are generally difficult and unwanted. So I'm sorry to hear that. Was your cousin that happened with your cousin? Did it happen more than once?
Yes.
Okay. How old were you? Do you recall?
I was really young, maybe 5 or 6.
Okay. Okay, great. Thank you for sharing that with me. And then last brief aside, now I'm just going to skip ahead. Any other experiences of adversity, difficulty, challenges that you haven't talked about that you want to talk about? Unexpected death or violent death of a loved one, having to leave a home when you didn't know you had to leave a home, becoming homeless, unfortunately, anything like that?
My mom eventually left my dad, and we didn't really know where to go for a while after that. So we stayed at some family's houses and sometimes in hotels, but then we got a house.
Okay, okay. Thanks for sharing that. Now I'd like to transition and ask, we're going to pass, quick aside, we're going to pass on talking about trauma symptoms and transition and ask, Megan, can you tell me, how do you manage the stress that you experience from these past events and any current stress that you're experiencing now? How do you manage stress in ways that you find helpful, useful, and they help you not only in the short term, but they even help you in the long term?
I talk to my mom on the phone a couple times a week, and that is always, she's my rock. I think I have a pretty good group of friends, and they all have kids, and so I can talk with them about, being a parent and all that. I go to church as often as I can with my work schedule.
Okay.
Yeah. I don't know what else.
Great. Great. So you have strong connection with your mom, strong connection with solid friends, and also, excuse me, and also strong faith community. That's wonderful. Those are really good, strong coping skills. Are there any skills that you use to handle stress, any ways that you deal with stress that you would like to change? In other words, maybe they're helpful in the short term, but in the long term, they ultimately don't serve you well.
Yeah, I think I yell too much.
Okay.
After I have a long day, I get angry pretty quickly at those times. I sleep a fair amount.
Okay.
And I don't know if I really enjoy having some drinks with my friends too. I don't know if that's helpful or unhelpful. But there's been a couple of times I've gotten pretty tipsy or feel like I want to have another and then another.
Okay. Okay. So you get angrier than you'd like, or you get angry more often than you would like. Very common. We hear that a lot. Perhaps you sleep more than you would like, is sort of what I heard you say. Is that true? Am I getting that correctly? Yeah. Okay. And that's also quite common.
As much as I like.
I'm sorry?
It's as much, I sleep as much as I like, but I do need to do other stuff sometimes, so.
Okay, so you're a little concerned that maybe you're missing out on doing things that you need to do. Okay, that's a helpful clarification. And last you mentioned you're not sure when you do socially drink if it's too much. It's just a question that you have, fair question that you have. Very good. Well, what we know is sometimes it's hard to change these habits that we'd like to change, particularly if they're related to stress, current or past stress. And usually it's in order to change them, it can be really helpful to seek support from maybe a counselor type, maybe friends, etc. But we find that we have a number of, we have a lot of relationships with counselors in the area. And we find that it can be helpful for people to reach out to counselors just so that they can support them in overcoming some of the challenges they're facing, overcoming some of the habits maybe that they want to lessen or remove altogether, and strengthen some of their positive coping skills. What are your thoughts about that?
Yeah, I'm open to it. I've seen someone in the past, but I could do that again. Yeah, I think it's helpful.
Okay, well, we'll talk a little bit about your past experience and how it was helpful, why it was helpful, what you think would be helpful in the future. So I'm glad you're open to it. That's great to know. Okay, so we'll go through a referral process. And then I'll ask the question, how likely do you think it would be, Megan, or how likely do you think it is that you'll be able to attend that first session with this counselor type?
Likely. I keep my appointments. Yeah.
Okay. Is there anything that could get in the way of it?
Just making sure that I don't like accidentally, pick up a shift or something if somebody offers anything. I don't think that'll happen, but I'm just making sure that I'm, work schedule wise clear.
Just scheduling out. Okay, that makes sense. Just ensuring your schedule is okay. And the people with whom we work, if you needed to cancel a session, that's not a problem. You can always cancel a session as long as you do it within a certain period of time, and then you can reschedule. So if you had to cancel, that's not a problem. And then lastly, I want to ask you, we've talked about some difficult life experiences. You mentioned that you experienced what we would refer to as sexual abuse at the hands of a cousin of yours while you were young and over the course of time. It wasn't just one experience. You mentioned you experienced physical abuse at the hands of your father, maybe not as much as one of your siblings, but it happened. So you were in a car accident that resulted in injury. So you've had some significant experiences, and you're having some significant traumatic experiences, and you're facing some significant stressors right now. I want to make sure that you're feeling okay in the aftermath of this conversation. So would you say, thinking back to when we started, do you feel worse, the same, or better than when we started talking?
The same, maybe a little bit better. Actually, I was a little bit nervous about going into it all, but I feel okay. Okay.
How come? Do you know why?
I got it, we got it out, and then we were talking about like how it matters, and current stuff, and then kind of what to do and what I if I'm interested, kind of like just asking me has helped.
Great. Yeah, we hear that a lot. I'm really glad to hear that. I'm glad that was your experience. So thank you so much for being courageous to talk about this. I think it can potentially help you feel a little bit better and stronger over time, but even help the work that we do. So I'm really appreciative. Thank you so much. Okay. We'll end there. We're a little bit over time. I apologize for that. Thank you, Megan, for being willing to pinch hit. I'm sorry, Lisa's technology is failing us. I'm sorry about that. But it was wonderful information and insights that she was able to give us. So why don't we open it up for questions now? We don't have a ton of time, but at least 7 minutes where we can address questions that people have posed, and hopefully can do so relatively quickly. So Luke?
Okay, so if you guys want to drop your questions into the chat box, and Luke is going to help read out those questions to our presenters. Give you a moment to do that, unless, of course, Luke, you have some ready to go.
Yep, I do. First of all, thank you, Dimitri, Megan, and Lisa for that presentation. Really appreciate it. And we've got about 5 questions, so we'll do the best we can to get through them. I'm going to start with the first question we received from Donnell. And the question is likely for you, Dimitri, which is the tool validated for youth?
Yeah, great question. We haven't used it with youth yet. There are a number of validated ACE tools, average childhood experiences, or childhood trauma tools that are validated for youth. So you certainly could replace our adult trauma screeners with a youth trauma screener. And then kind of plug and play, go from there. I can't imagine what are the concerns in implementing it with youth. There may be some needs to tweak it, but we have yet to do that ourselves. We'd be happy to talk with people about doing that and maybe even potentially testing it. But it's a good question, I think the questioner Darnell is I'm sorry if I'm getting your name wrong, but I think you're asking a great question. Lisa, can you hear us, or can you speak now?
Yes, can you hear me?
Yeah, we can. That's great. So you can help me answer any questions. So next question, Luke.
Yes, the next question comes from Shem, and it is regarding what sort of grounding skills are used in the T-SBIRT protocol.
So I can start that, and then Lisa, you can end that. Briefly, we use an exercise that was developed by Edna Foish. She's a luminary in the trauma studies world. It's a very simple breathing exercise where we breathe out slowly, stop, count with the client, and then breathe in a somewhat regulated fashion. So we regulate breathing, and once breathing is regulated, generally speaking, mood becomes regulated. And we have found when we implement it, clients generally appreciate it, like it, they feel better in the aftermath. Do you want to share any experiences around that, Lisa?
Generally, the participants that we work with, none of them, I think only one required the breathing exercise.
Right.
And we follow up to ask them how they feel, if they feel better or worse, slightly better. And the majority of the time we get that they actually feel better, that, you know, that they've been able to talk to us and we listened.
Yeah, well said.
Great, thank you. There is another question from Donnell that is specifically for Lisa. Lisa mentioned that it was challenging to find services. Can she highlight where there may be a shortage of particular services that people need?
For our participants, we work with a lot of Spanish-speaking participants, so we don't have a lot of resources for our Spanish-speaking participants, so that's one example. Another example that we find a lot is for housing. That ends up being something difficult to find resources for. So I guess my answer would be just in general, depending on what they need, it may be difficult to find the actual resource. I don't know if that makes sense.
Yes, absolutely.
We also find that it takes a lot of effort to actually connect with trauma-focused interventionists that work with adults, particularly adults who might be underinsured or uninsured. So we had to pound the pavement. There are a number of agencies, of federally qualified health centers, other clinics that we have partnered with that will take clients who are underinsured or uninsured and provide behavioral or mental health services. And potentially they have trauma-focused specialists. Nonetheless, there's a great capacity problem in our city with this particular issue. I'm not suggesting that mental and behavioral health treatment is the be-all and end-all, but it's part of the solution. And we need more mental and behavioral health specialists who are trauma-focused, who know how to address trauma effectively, will take under or uninsured clients, and frankly, who can conduct culturally relevant work and culturally sensitive work. So we need more Spanish-speaking interventionists, for instance. We need more interventionists of color. And we have a program at UW-Milwaukee where we're working on this, but it's going to help, but it's not going to solve the problem.
Great, thank you both. We have a question from Rebecca, and it starts with, are there any credentials or professional licensures required or recommended to using T-SBIRT and the accompanying screening tools?
No, that's the beauty of the protocol. Just like SBIRT, it can be implemented with doctoral level practitioners, master's level practitioners, BA level practitioners, practitioners with associate's degrees, and practitioners who don't have advanced degrees. The big question, so there are no credentials required, educational or licensure or otherwise, credentials required to actually implement the protocol. The The big prerequisite, as Lisa mentioned, is just the ability to be present to clients' experiences of trauma and adversity. And that requires some maturity, it requires practice, it requires skills. Sometimes it requires being aware of and comfortable with one's own experience of trauma. We worked with a number of practitioners who have selected out of the pilot, and a number who've selected in. Some said, I just don't want to do this. It's taking me in a direction I'm not comfortable, and we honor that. And some argue that, well, I really like doing this. It helps me become closer with my client. It helps me enhance my professional development, et cetera. So the biggest prerequisite really is comfort and ability to deliver the protocol. And who does it within a certain setting really depends on the workflow of that setting. We've had nurses conduct it, nurse home practitioners conduct it, we've had case managers conduct it, we've had supervisors conduct it, et cetera. It's a great question. The answer is relatively open-ended.
Great. So we have one more question, and then we'll wrap things up, especially around kind of next steps, because there have been some questions about how to learn more about T-SBIRT, or how, for that matter, to bring it into one's agency. But the last question I have here is from Derek, and it is, do you feel this can be utilized to help guide treatment planning in residential treatment?
I would argue yes, in that it provides a relatively efficient way to collect this information from clients. I would recommend that it be implemented perhaps not the first day, when there perhaps is some rapport built between the resident and the interventionist. But nonetheless, I think it could accelerate the relationship building as well as the treatment planning. So I don't see why it couldn't be used within an assessment context.
Excellent. Well, thank you, Dimitri and Lisa, again, for all of your insights on the development of and the use of T-SBIRT. We appreciate you as well, Megan, for sharing your experience with us today and for stepping into the demonstration. We appreciate all that you do to advance the use of T-SBIRT and are grateful for your reflections and guidance today. We also would like to thank all of you for joining us today. We hope that you found today's conversation helpful and inspiring. We value your participation and feedback, so please take a couple minutes to complete the brief survey that follows the webinar. We will send you supportive materials from this webinar next week. And as some of you have asked about the implementation of T-SBIRT, please don't hesitate to reach out to me or directly to Dimitri. If you enjoyed this webinar, we will be hosting upcoming webinars on topics such as strategic learning, housing, and telehealth, or you can receive updates on upcoming webinars through our newsletter mailing list, exploring our website, or following us on social media. Thanks again for joining us, and have a wonderful day.